My name is Strasburger, and I'm with Community Memorial Hospital in Syracuse, so just down the road, about 25-30 minutes from here. But we're actually going through a rebranding. So it's Community Memorial Hospital today, but we're actually building a replacement facility and going to be moving in around November 10th. So then we will be Syracuse Area Health. So not too far away, but we are excited and happy to be here. Dr. Scott Strasburger is here, going to give you a fantastic presentation. And he does surgery, performs the surgeries with this robot you're going to hear about. He does that at our facility, in our operating room there. So very, very excited to have him and his crew and his team. And they can also see patients right there in Syracuse for consultations, as well as the surgeries and the follow-up here and all that. So we'd be happy to take care of any of you or answer any questions that we can post this session here. But I'm sure he'll do a fantastic job that you might not even have any questions. So I want to introduce Dr. Scott Strasburger. He's a board-certified orthopedic surgeon specializing in sports medicine and has been practicing medicine for over 18 years. Dr. Strasburger is originally from Holdridge, Nebraska, and received his bachelor's degree in life sciences from Nebraska. He played football for the Cornhuskers. Let's hear it go Big Red, right? Woo! Yes. Dr. Strasburger attended the Nebraska Medical Center School of Medicine and served a surgical internship at the University of Tennessee College of Medicine in Memphis. Dr. Strasburger returned to Tennessee for his orthopedic residency and received advanced training at the world-renowned American Sports Medicine Institute in Birmingham, Alabama. Dr. Strasburger specializes in complex shoulder issues, rotator cuff injuries, shoulder instability, shoulder and knee replacements, ACL, and all other knee and sports-related injuries. He also has years of experience helping patients with other orthopedic and sports medicine needs. So please join me in welcoming Dr. Scott Strasburger.
This is a first to me. I guess we're on Facebook Live. So this is a first for me. I'll say hi to my mom and dad down in Phoenix because I know my mom's probably the only one watching down there. And yes, Mom, I know it's 100 degrees here and it's hotter here today than it is down in Phoenix. That's my background. I'm from Nebraska. I love being in Nebraska. I've been back in Lincoln for 20 years. I've been practicing orthopedics in the Lincoln area since 1996. I have a lot of surgeons to thank for training me to get me to the point where I felt comfortable doing knee replacements. And I've learned a lot from a bunch of different people. But I probably learned more from one little robot in the last 3 months than I have from all the surgeons that I've worked with in the past 25 years. And that brings us to a point. How do we get a $1 million robot into the cornfield of Nebraska? And that came with surprising ease. I have been fortunate to work with Brad Kyle, who's another rep from Smith Nephew for the last 20 years, who's been a great friend and a great business partner to work with. But what Brad has always done is challenge me to become a better surgeon. And sometimes in orthopedics, we get very stagnant. We think we've learned everything, and sometimes things don't change significantly. But Brad has always challenged me to learn more. And when robotic surgery came out, he stepped up again and said, "Hey Scott, you need to be a part of this. This is something special. This is going to make you a better surgeon." And believe it or not, that's our goal, is to become better surgeons so we can provide better care for all of you. So we had this great technology, but I had to somehow get it to the great state of Nebraska. So I approached the Syracuse Area Community Health Center and went to their board, and in great wisdom and foresight, they had the courage to invest in me and this robot, and we've created this robotic total joint program in Syracuse now that we're incredibly excited about and really looking forward to great things in the future. We have a state-of-the-art facility that will be opening up in a matter of weeks, and in combination with this NAVIO robotic program, I look forward to many great years with this. So this is that little robot I've been talking about. This is a handheld piece, and this is part of the system. It allows us to be much more precise with our cuttings. It allows us to obtain information that we were previously unable to obtain. So these pictures depict what we're talking about, arthritis. On the left side of our screen is a normal knee that has normal cartilage on the end of the thigh bone. On the right is a picture that depicts advanced arthritis. And arthritis essentially is the wearing out of the cartilage, and it occurs in all of us as we age, some of us more quickly than others. We diagnose arthritis by talking to the patient. Oftentimes patients tell us everything we need to know. We do a history and physical, and then we take x-rays. These x-rays often show the information we need to know. Again, here on the left it depicts a normal knee. We have a normal joint space there. In the middle of the knee, you can see a space between the end of the thigh bone and the proximal tibia. The picture in the middle shows a knee that's starting to wear out on the inside part of the knee. So this would be arthritis that affected a single compartment, and this would be an x-ray of a patient that may be a candidate for a unicompartmental arthroplasty. I was going to come back to this x-ray later in the talk and show you something, but I want you to remember this x-ray. I'm going to refer back to it. Most x-rays of people with arthritis that is unicompartmental or occurring on only one part of the knee have very uniform pictures. The rest of the knee looks fairly good. They have a fairly straight knee. They don't have significant deformities. As the arthritis progresses, we can end up with significant deformities. We can end up with extremely knock-kneed or extreme bow-legged. Sometimes the knee won't go straight and oftentimes won't bend very well. We treat arthritis the usual ways. Weight loss is something physicians always tout. It doesn't happen and work very well most of the time. Changing the lifestyle is an option. Oftentimes that's not a positive. Unfortunately, we take some of the activities we love to do, walking a dog, playing with grandkids, playing pickleball, golf, hiking. We have to eliminate those due to the pain. Other treatment options include injections. This may be cortisone, which is a temporary treatment. This may be viscosupplementation. It could be medicines like Synvest. I kind of consider these the WD-40 of the knee. They lubricate the knee temporarily. Other options are TENS units and braces, and then stem cell research is showing some promise. It's not a long-term treatment for significant osteoarthritis at this time. Partial knee replacements are an option. They are technically more demanding than a complete knee replacement. There's a limited patient pool. Approximately 20% of people with arthritis are candidates for a partial knee replacement. If you are a candidate for a partial knee replacement, there are certain criteria that must be met. You may not have an inflammatory arthropathy like rheumatoid arthritis or psoriatic arthritis. Those arthritises usually affect the entire knee, so we rule you out as a candidate. You need to have an intact anterior cruciate ligament. You need to have no lateral compartment arthritis or arthritis behind the kneecap. You have to have normal ligamentous alignment or correctable deformities and not have a flexion contracture. So those are some of the criteria for a partial knee replacement. There was an interesting study that was done in Great Britain that looked at 100,000 patients who had had knee replacements. And they found that by criteria, 20% of those patients would have been candidates for a partial knee replacement. And sometimes less is better than more, meaning if you're a candidate for a partial knee replacement, why wouldn't you get a partial knee replacement? Well, if 20% of the patients, by their definition, are candidates, then why in the United States are only 8% of knee replacements partial knee replacements? And part of that is due to the complexity of a partial knee replacement. We as surgeons have become very good at doing total knee replacements, and a lot of surgeons will say, I don't need a stinking robot to do a knee replacement. I've been doing it for 30 years. But if knee replacements are not so complex, then why is 20% of all knee replacements are candidates for a partial knee replacement? Why aren't 20% of them getting a partial knee replacement? And that is due to this complexity. And how can we address that complexity? Well, that's where the NAVIO robot comes in to play. Well, the interesting thing is the x-rays before surgery look very uniform. There are not many changes. If I took 5 x-rays from 5 patients who were candidates for a partial knee replacement and put them up on the screen, they look very similar. Yet if you look up here and you look at the after x-rays, all these x-rays look different. And these are x-rays done by very competent knee replacement surgeons. And you can see that there's not much uniform appearance to these knee replacements done the traditional way. But when you throw the NAVIO robotic system into the picture, these are 4 patients. and I can't tell the difference between any of the x-rays. And that's what we're looking for in partial knee replacements. One of the reasons they're not done routinely is they are a much more complicated operation. The NAVIO works very well in making this complicated operation less complicated. And it's giving us the confidence to do this operation. I feel confident doing a partial knee replacement in the OR, but when I sit down and talk with you in the office, and I know we're going to use the NAVIO system, I have much more confidence telling you that I know what kind of result you're going to get after surgery. This is just, and a lot of you saw this while we were waiting to start the program. This is just an intraoperative depiction of what we do with a partial knee replacement. It shows us registering the knee, which essentially means we're mapping out the knee, where the knee lives in space. We're putting that information on a computer. We're evaluating how the knee moves, which makes the NAVIO much different than any of the other robotic systems. A lot of the other robotic systems will gather their preoperative information or their information preoperatively with CT scans. What the NAVIO does is it allows us to gather the information intraoperatively by how the knee functions. If we're in Nebraska, so we got to talk football. So if we're looking at a Husker football recruit and you want to see if he's any good, do you want to see a picture of him? Or do you want to go on Huddle's website and watch video of him? I want to watch video of him. I want to see how he functions when he's running. The NAVIO is the same thing. It allows us to map out where the bones are intraoperatively, but it also allows us to see how the ligaments are functioning. So we can put a knee in that's specifically designed for not only your bone structure, but also how your ligaments and other soft tissues are working in your knee, which gives us a much better result. We've left plenty of time for questions tonight. This is the part of the night that always makes me nervous because some of you have been online looking at things and some of you might be better educated in certain parts of this than I am. So I'll field questions if anyone has any.
Excuse me, sir, I have to leave.
Okay.
Hopefully, I will return.
All right.
Can you get the door open?
Take care of it.
Yes, there.
Can I repeat the question?
Yes, ma'am, thank you.
I'll repeat the question. It was, will Medicare take care of this?
And yes, they do. Obviously, the technology is significantly better than what we've used. Medicare has not recognized that yet and does not reimburse us differently, but they do cover it for how it is right now. And we are doing a lot of older patients with it.
And how long of a hospital stay is this procedure?
And that differs from patient to patient. Knee replacement is now being done on an outpatient basis. People are being done at 7 o'clock in the morning and being sent home at 5 o'clock at night. That's with a total knee as well. Partial knees, that's very common, but total knees, some places are doing that. Again, that's based on age, health issues. Most patients are staying 1, 2, or 3 nights. I believe Medicare allows patients to stay for 3 nights.
How is this different than the procedure that is utilized by one of your, I guess, peers, Dr. Bigelow, with the computer system?
With regard to other robotic-assisted navigation systems, and there are other systems out there. The one used in town is a Da Vinci-like program that utilizes preoperative CT scan evaluations to determine the computer-generated cutting system. So we use x-rays in determining how to make the cuts to balance the knee. That differs from the NAVIO system in that the NAVIO system gathers that information based on landmarks that we obtain in surgery. So we obtain where the center of your hip is by moving your hip and evaluating that with motion analysis in the OR. We evaluate where the middle of your ankle is based on bony landmarks in the OR. And then we take and put location devices on the thigh bone and the leg bone during surgery to see how the position of the knee lines up with regard to the hip, the knee, and the ankle. And then we use that in combination with how the knee moves. We stress the ligaments while we move the knee to gather further information. So we combine not only how the bone lines up, but we combine that with how the knee is moving, which is a little bit different technology than what other physicians are using in the area.
I have a question over here.
Doctor, my name is Wayne, and can you hear me better this way? I don't mean to boast. I've been skiing aggressively for 50 years, and that's all part of the story, and I don't mean to say that here, but 9 years ago, I was skiing moguls at Squaw Valley, California, in which I tore my left ACL. Well, the ACL was repaired. I've continued now to ski for 8 years or so, but in the mogul field on Copper Mountain not too a year ago, I felt intense pain. I went down and I thought the ACL was gone. So I went to a doctor my daughter recommended in Omaha, and he conducted a test and said, I do have a little bit of arthritis, not too bad, but my meniscus is torn. And so he performed, scoped the knee, screwed, cut the loose ends, I guess, of the meniscus. And that seemed to help. I don't feel any problem walking and so forth. He told me not to run, not to ski bumps anymore. But I went out to ski last December without some cortisone and found that very difficult to ski with that pain. And so I got a cortisone shot, and in January, ski with no problem at all. And I don't know how much longer that cortisone will be effective or how long it will last, that kind of thing. And I don't know what I'm set up for, a knee replacement at some future date. No doubt I'll see my doctor about that. So I won't leave you with a question, but with an answer. And the answer is that the doctor who performed the ACL 9 years ago is in this room at this time. Guess who?
Well, I came in late, so perhaps you covered this. Is this covered by Medicare?
Yes, it is covered by Medicare.
I have one other question. Do you feel that Scott Frost will eventually get the job done?
I will tell you, as confident as I am in using NAVIO technology, I am equally that confident that Scott Frost will get the job done. As much confidence, and I am a friend of Scott Frost, and occasionally they have very similar personalities.